Welcome to this medicine masterclass on inflammatory bowel disease. Inflammatory bowel disease is comprised of two major disorders, ulcerative colitis and Crohn's disease. These disorders have somewhat different pathological and clinical characteristics, but also have a substantial overlap. Ulcerative colitis, which particularly affects the colon, patients present with diarrhea, which can be bloody. Bowel movements are frequent, small in volume, and as a result, lead to rectal inflammation. Other symptoms include colicky abdominal pain, urgency, tenesmus, and incontinence. Patients may also have systemic symptoms including fever, fatigue, and weight loss. Crohn's disease, which is a disease that can affect the entire GI tract from the mouth to the anus, can also result in abdominal pain, diarrhea, which is usually a common feature, but can also result in symptoms related to malabsorption, particularly when the small intestine is involved. Bile salt malabsorption can lead to watery diarrhea and steatorrhea. Protein malnutrition, hypocalcemia, vitamin deficiency can also result in metabolic bone disease. Let's take these two conditions head to head. Both of these conditions are relapsing and remitting inflammatory diseases. Ulcerative colitis tends to affect the colon, starting with the rectum, spreading contiguously proximally with occasional backwash ileitis, whereas Crohn's disease can affect the entire GI tract from the mouth to the anus. Endoscopically, in ulcerative colitis, the colonic mucosa appears hyperemic, red, hemorrhagic, and friable, and you also note crypt abscesses and goblet cell depletion. In Crohn's disease, endoscopically, this is a transmural disease which leads to fistulas developing, skip lesions, a predilection for the terminal ileum, and a cobblestoning, rose-thorn ulcerative appearance with strictures. Ulcerative colitis is T helper 2 mediated, and Crohn's disease is T helper 1 mediated. There are a number of extraintestinal manifestations of both of these conditions. Patients may appear clubbed. The skin may demonstrate erythema nodosum or pyoderma gangrenosum. Eye signs include iritis, episcleritis, and conjunctivitis. The joints may be affected with arthritis, sacroiliitis, or ankylosing spondylitis. There is an association with liver conditions such as primary sclerosing cholangitis, cholangiocarcinoma, fatty liver. Importantly, in Crohn's disease, look out for aphthous ulceration in the mouth. Complications: as ulcerative colitis affects the rectum and the colon, toxic megacolon and perforation are serious complications, as well as ongoing bleeding and colonic cancer. In Crohn's disease, the patients can develop small bowel obstruction, perforation, fistula formation, as well as cancer. We score ulcerative colitis and Crohn's disease using various criteria. For ulcerative colitis, we use the Truelove and Witts criteria to assess the severity of disease, which helps determine the degree of management for the patient. Crohn's disease activity can be monitored using the CDAI, or the Crohn's Disease Activity Index, and a CDAI of less than 150 indicates remission, whereas a CDAI of over 450 indicates severe Crohn's disease. So in ulcerative colitis, the Truelove-Witts severity assessment assesses the number of motions per day, the presence of rectal bleeding, whether the patient is febrile, whether their heart rate is increased, their hemoglobin and ESR, and these are then scored mild, moderate, or severe. Now let's take a case-based approach. We have a patient here who presents with increased bowel movements. What type of things would we expect on examination? So we noted that the patient was comfortable, and you could see that the patient had a midline laparotomy scar, which was 10 centimeters and well healed. But there was no evidence of stomas, no previous evidence, and no current stoma. On palpation, there was no evidence of abdominal tenderness or organomegaly. The abdomen was resonant with no signs of ascites, and on auscultation, bowel sounds were present and normal. On inspection of the hands, there may be early clubbing. This is uniform swelling of the terminal phalanges of the digits, leading to a loss of the angle between the nail and the nail bed. On the legs, you may see evidence of pyoderma gangrenosum. This is a condition that causes the tissues to become necrotic, causing deep ulcerations which demonstrate pathogy, which means irritation or minor trauma can increase the disease. You'd offer a differential that this patient has had inflammatory bowel disease, likely Crohn's or ulcerative colitis, with previous bowel surgery, either due to bowel obstruction or due to malignancy. Some patients with inflammatory bowel disease will have a stoma. So let's take a case and see how we would discuss and present such a case. So you can see here, Mr. Jones presents to the clinic for a review. Now, on inspection, the patient appears comfortable at rest. You can also see a midline laparotomy scar, but in this patient it's more subtle because the scar has now aged. This was a surgery that had happened a long time ago. There is a stoma. The stoma is in the right iliac fossa. You note if you were to remove the bag, it was spouted. And if you examine the contents of the bag, you'd note liquid fecal effluent. You should digitally or offer to digitally examine the number of lumens in a stoma. And if there's one lumen, you could comment on that, or if there's two, that would suggest a loop ileostomy. Comment on the surrounding skin. Is it healthy or is there erythema or signs of infection? Comment on whether there's any herniation or peristomal complication. And as there's one lumen, this is likely to be an end ileostomy. When you palpate, there should be no evidence of abdominal tenderness or organomegaly, and there'll be no evidence of ascites. Auscultation reveals normal bowel sounds. Let's just talk about the stoma in a little bit more detail. Stomas can be in the left iliac fossa or right iliac fossa. Right iliac fossa, we saw in this case, are usually ileostomies or urostomies, and left iliac fossas are usually colostomies. Ileostomies and urostomies are both spouted because their contents are irritant and toxic to the skin. The way to discern them is their effluent. A urostomy would result in urine, an ileostomy would result in soft stool or liquid effluent, and a colostomy would have hard stool. The number of lumens is important. One lumen would suggest an end ileostomy or urostomy. One lumen in the left iliac fossa would suggest an end colostomy. Two lumens close together would suggest a loop ileostomy or a loop colostomy. And we should examine the patient for any evidence of peristomal herniation or retraction or necrosis. And here you can see this patient. Stoma complications to be aware of include prolapse, where the stoma appears abnormally extended out through the abdomen, and that could be made worse when the patient coughs or strains and normalizes when the patient lies down. Conversely, the stoma may retract and may sink below the level of the skin and would appear concave. The stoma can infarct, and that would be due to inadequate arterial blood supply, and the stoma may appear black as a result of necrosis. The stoma may bleed as a result of malignancy or any other superficial trauma, and that would be known as a stoma hemorrhage. The stoma can also become infected and result in sepsis. So for patients with inflammatory bowel disease, a number of important investigations are required. A number of blood tests to look for infection, bleeding, the Usenes, the LFTs, clotting, as well as blood cultures if there's evidence of septicemia, and a blood gas. The urine and feces can be analysed for microscopy, culture and sensitivity, and they may require imaging, such as a chest radiograph, particularly an erect chest radiograph if you're thinking about perforation, an abdominal X-ray or ultrasound, or a CT scan to monitor disease activity. For inflammatory bowel disease, an MRI of the small bowel may be required to look at detailed changes. And all of these investigations should be reviewed in the context of previous investigations to see whether the patient is improving or deteriorating. Crohn's disease, the main aim is to induce remission and then maintain remission. Inpatient therapy is required for those patients who are acutely unwell if they've developed a complication such as small bowel obstruction or peritonitis, or a disease flare that's not responding to outpatient therapy. And patients are treated with intravenous fluids, electrolytes are replaced, they may require intravenous antibiotics, nutritional support, and involvement from the gastroenterologist and the gastrointestinal surgeons. Patients may be treated with intravenous steroids or biologic therapies. Similarly, patients with ulcerative colitis, the aim is to achieve and maintain remission, and although glucocorticoids may be effective, biologic agents tend to work very well for moderate to severe ulcerative colitis. For ambulatory patients with ulcerative colitis, anti-TNF therapy with infliximab, adalimumab or golimumab may be useful in selective patients, or anti-integrin therapy such as vedolizumab or anti-interleukin 12-23 therapy with ustekinumab. Bear in mind that for refractory cases, patients may require surgery. For ulcerative colitis, which is affecting the rectum, they may require a proctocolectomy and a terminal ileostomy if there's severe backwash ileitis, and they may require an ileoanal pouch. Crohn's disease patients undergo multiple surgeries for multiple small bowel resections and may require a colonic resection too. So in this discussion, we've covered inflammatory bowel disease, we've compared and contrasted Crohn's disease, as well as outlined the investigations and management. Thank you for attending this medicine masterclass.